Arthritis is just a term used to describe a joint that is painful. And it's painful because the bearing surface has been damaged. The bearing surface in a person is the cartilage that you have on the ends of your bone. And that is bone on bone, which becomes very painful, very stiff, and causes lots of problems. To say millions of people are affected is probably underestimated. Almost everybody, once they get beyond their 20s and 30s, has some element of arthritis. It can be minimal, that bothers you with inclement weather, or it can be rather major, where you have difficulty walking and it affects your daily living. There are two forms of arthritis, degenerative and rheumatoid, and they're very different. Osteoarthritis is basically the wearing out of a joint, and I would say the majority of that is due to trauma. We have a lot more people participating in athletics, and when we repeatedly injure a joint, you damage your cartilage, and that poses a problem on down the line. There's also degenerative arthritis due to genetics, and rheumatoid is an autoimmune disease process, and that basically affects not only the cartilage, but it also affects soft tissues. So that's a much worse form of arthritic change. I really like this picture because this to me is the best analogy I can give for a joint. You've got a brand new tire here with a tire tread. Eventually, as you use that tire, it's going to wear out and become bald and may need a recapping. Our joints are really the same way. We wear out our cartilage, we have pain, and we resurface them, which is just like a recapping of a tire. Arthritis is sort of funny in the way it affects you. You may end up just all of a sudden having pain. And you go to the doctor, my patients come to me and say, well, gee, it only started bothering me 2 months ago. Well, that process has been developing over years. And you may not have a lot of pain, especially if you have a high pain threshold, until you get down to bone on bone. When you get down to bone on bone, that's rough, it's catching, and it's really painful. This is basically just a sign of the stages of arthritis of the knee. If you're looking here, there's just a little bit, and it's in an area that's non-weight bearing. That probably doesn't bother that person if there's a person with a picture like that. As it progresses, you start to see it in the weight-bearing surfaces, and then you're starting to have trouble and some swelling. When it gets to this final stage over here, that's really raw bone on raw bone, and that basically presents a lot of swelling and a lot of pain, and it's very uncomfortable. This is just an x-ray of a hip. You should see a joint space area here. There's none here with this. This is, again, bone on bone, and it's almost a frozen hip. This hip is very stiff. When you have a joint replacement, you should expect that you would have reduction of your pain and that you should get back to the things that you want to do. And everybody's different. I mean, I've got people who are very grateful just to get to the grocery market because they couldn't do it. Joint replacement is one of our most common operations, and I think this is an outdated slide here. Literally, it's doubling every 5 to 10 years. I saw a statistic recently where it's going to be 4 or 5 times what it is now, and we may eventually have trouble getting enough physicians to be able to perform this. Another interesting concept is minimally invasive surgery, and that's really been around for about 10 years. And what I'd like to say, that doesn't mean minimal incision surgery. It means minimally invasive. And the difference is that you have the ability through instrumentation not to cut the muscle. When we do a hip operation now, we don't cut the muscle. When I do a knee replacement now, I do not cut the muscle. Because of that, you have less pain and you're able to rehab more quickly. This shows you why it's this instrumentation that has been developed. This is a very small incision. This is the socket on a hip replacement. It shows you how deep that is. And we didn't used to have this instrumentation, so we have to use these huge incisions to be able to get in. And this is really, I think, an advance in what we do. This, again, shows you the old incision was this. The new incision is really pretty much like here. But again, this muscle here, when we did that incision, see all that muscle underneath? We had to cut all of that. And it damages the muscle, causes a lot of pain and swelling. What we do now is we're able to take this muscle and retract it over this trochanter here. And so if there's any here, we split it, we do not cut it. Here we have the socket that's put into the bone. We have the polyethylene liner that fits in the socket. We have a cobalt chrome head, and then we have this, which is made of titanium. The only part that's important is right here, this porous coating. This is what sits in, and once that bone grows into that after about 6 weeks, it's very difficult to get these joints out. I think these joints will last indefinitely at this point in time. This is just the procedure of preparing the proximal, the thigh bone for surgery. Essentially what we do is we remove the head and the femoral neck. We put a reamer down into this canal, and then we put the prosthesis in. Now, this down here is really just to stabilize it. It really has no effect after about 6 weeks. The important part is this here. This is the porous coating that the bone grows into. And once it grows into that, in a titanium porous coated implant, you can't get these things out. They really are there forever. And the interesting thing about that is all these years I've done these joints, I've never seen a joint loosened by trauma. I'll see somebody break their femur beneath the joint, but the joint, once it's in, if you get past a year, it's not going to move. And this just shows you the completion of that. And of course, the difference is you've got a socket here that's in the pelvis, and then you've got the hip down in here. And this just shows you porous coating, the bearing surface. This is polyethylene, this is cobalt chrome, and this is titanium. And this is the x-rays. In this particular case, the surgeon used screws here. This is not my patient. Most of the time, we can get such a good fit that we don't need to use screws. But if there's any question of the fit, we use these screws to hold this porous coating against the bone. Remember, what we're trying to do is get bone to grow into the prosthesis, and that can't be moving in the first 6 weeks. These things should last indefinitely if you don't have a complication the first year or two. As a surgeon, I love this computerized assist, and I'll go on that. This just shows you the actual model. This is the infrared, and this shows you the screen. This shows you a hip, and you can check with, it's important in doing a hip, one of the major complications is dislocation. And of course, you want to be in perfect position so they wear. So the abduction, we can measure it. And when you do it manually, it's really hard. I mean, I did it manually for 30 years, but I can be within a degree or two on here, and I was never that good manually. This is one of the operative ones. The next one you may want to turn your head on. But all this does, this shows you the tracker. It's a little dark, and there are balls on the ends of this tracker. And we digitalize the pelvis, and I won't tell you how we do that. We take bony points on the pubis, the other iliac crest, and then we compare it with a level surface. And once we digitalize the pelvis, we know where that pelvis is. When you're operating on someone, they're on their side. Most people have more weight than they should, and you can't really tell where the pelvis is at. So you look at it and you think you know where you're at, and you really don't. With this computer, when we digitalize this, we know exactly where we're at all times, and that's really exciting. This is the bad picture. This sort of shows you how difficult a hip is. This is a big hole here. You see all the fatty tissue. This is the tracker with the balls on it, and the shell is way down there. You can see how hard that is manually to position that. And yet with this computer, I know exactly where that's at all times. And this just shows you an incision. That's not the important part. It's probably about a hand's breadth incision. This way we closed. And you have to have enough incision to see what you're doing. And in this particular patient, there was quite a bit of fatty tissue. So you have to be able to see somewhat the computer. You can't do it blindly, even with the computer. Going on to total knee replacement, this just shows you the implants. And essentially, we have the same thing that we had in the hip. It's just a different implant. We have a titanium shell, a polyethylene liner, cobalt chrome on the femur on titanium. This shows you the anatomy of a normal knee. And the important thing for you is the surface, the cartilage. That's what you walk on. This is a knee that wouldn't be causing anybody any problem. Now you start to get a problem, you see that roughening. When you look at early, and I do a lot of arthroscopy, when you look at early arthritis, it looks like somebody took sandpaper to the cartilage, and that's what early arthritis is. And then as you get further along, again, we have these things, that's raw bone. And when you go in there, you open up a knee joint, and fluid will come out, and you can just see how painful that is for people. Total knee replacement, you know, most women are a little valgus, and most men are varus. This is where you should be normally. When we finish our surgery, we would like the men to be straighter. We'll leave them within a degree or two of varus, and the women maybe within a degree or two of valgus. This shows you just a cartoon of how you resurface a hip, or a knee. We resurface the kneecap. This shows you that. This is the femur, and this is the tibia, the lower bone. Again, it's titanium, polyethylene, cobalt chrome. That is the bearing surface that I use, that has been used really for about 40 years. This shows you, again, a knee replacement. This is after it's been done. This is the x-ray. This is a well-seated knee replacement. You don't see the polyethylene like you don't see cartilage on an x-ray. And that's really in very good position. This is this is one of my patients. This is a really good shot of what minimally invasive surgery is. This is the major muscle of the knee, the vastus medialis. I've cut no muscle here. I've opened an incision that's about a hand's breadth, and I've cut capsule. This is just rotated over. You can see the kneecap here. When we put the knee in, we rotate it back. So we essentially do this operation without cutting any muscle, which makes it a lot easier for Vincent to rehab you, and it makes it a lot easier for you to do it too. When you use the computer, you make cuts on the thigh bone, the femur, and on the leg bone, the tibia. And this shows a cut through the thigh bone, varus valgus. Remember we showed you that with the knock knees and bull legs. This is right where it should be. It's at 0. And you can't see that without the computer. There's been a lot of talk about gender-specific knee. And this was developed by Zimmer. It happens to be the knee that I use. I have no financial relationship with them. But the thing I like about it, the difference is that rather than having the normal sizes, there's like 6 sizes of the femur, they developed 12 sizes, so you have twice as many fits. And the fitting is so much better, you're less likely to have a mal-fitted prosthesis by using this, just because you have more sizes. The rehab is extremely important, more for knees than hips, but how well you do then depends on how you rehab. But everybody's different. We used to tell people to stay on crutches for 6 weeks. The other thing that we used to do is to restrict people. But at this point in time, the only thing that I don't have people do is running. Like I said, I have them skydiving, I have them come down, I have them skiing, and I really don't restrict them because I can't see why I would want to do it at this point in time.